Good morning, everyone. At the outset, I would like to thank the organizers for inviting me and keeping a session on sleep, which I still think is a very under-recognized aspect of our clinical practice. So I'm running a sleep clinic in Bhopal, and we have done around 170 sleep studies as of now. And what I noticed that around 80% patients of ours were men and 20% were females, but all were menopausal. So let's talk about COMISA, which is comorbid insomnia and sleep apnea, which is very common in today's Indian population. I'll start with a case scenario. She came to us, she was a 48-year-old female, post-menopausal from last 3 years. She had insomnia, she had difficulty in falling asleep, and she even waked up early and she had frequent arousals during night. She was tired throughout the day. She showed to her physician and she was managed with escalating doses of benzodiazepines. She was also added antidepressants. This is a very common scenario in our day-to-day practice in which females are given antidepressants and benzodiazepines for sleep problem, but she had no meaningful clinical improvement. So we did a sleep study for her, and what we found that she had severe obstructive sleep apnea. Her AHI was 44. The normal AHI is less than 5, and her AHI was in severe category. She was diagnosed as comorbid insomnia and sleep apnea, which is the co-occurrence of both chronic insomnia and obstructive sleep apnea in a single patient. Around 10% of the problems in menopause are related to sleep. Insomnia in menopause. So every third post-menopausal woman is suffering from insomnia. It may be trouble falling asleep or trouble staying asleep. And 40% of post-menopausal women, they sleep less than 7 hours a night. 7 hours is the adequate amount of sleep that should be there. And over half of them wake up feeling tired most days of the week. Now talking about sleep apnea and menopause, so what we see that during the pre-menopausal phase, the incidence, the prevalence of sleep apnea is very less in women. But this changes as they transition to peri and post-menopausal stage. It is in the before 45 years of age, men are more likely to have sleep apnea, but after 45, it is women who are more likely to have sleep apnea. And how does sleep apnea occur? That I want to show in this slide. Normally when we breathe, the air goes through our nose, then through our pharynx, and then to the trachea and to our lungs. But what happens in sleep apnea? There is collapse, the pharyngeal dilator muscles, they relax, and there is increased collapsibility of the upper airway. It is a problem of upper airway. Because of the collapse in upper airway, there is fall in oxygen saturation during sleep. And when there is a fall in oxygen saturation, there is a cortical arousal. Because the chemoreceptor sense the fall in oxygen saturation, they signal it to the brain. The brain asks the pharyngeal muscles to dilate the upper airway, and in turn, the patient transitions from deep sleep to light sleep. So there is sleep fragmentation, and there is recurrent episodes of fall in saturation. And because of this, there is increased risk of cardiovascular disorders, and there is tiredness throughout the day. So I'll see if this video is... This is how sleep apnea occurs. So while we sleep and go to the deep sleep, our tongue falls, the pharyngeal dilator muscle activity decreases,
or shuts as
and
you
the
inhale
airway
when the
collapses.
muscles relax. Your blood's oxygen level may decrease if you don't get enough air. When your brain detects that you are having trouble breathing, it abruptly wakes you up so that you can clear your air passages. This awakening is usually so brief that it is forgotten. Each hour throughout the night, this sequence may repeat itself 5 to 30 times or more.
So why this incidence of sleep disorders increases in menopause? This has already been discussed. So estrogen, it dilates the upper airway. In menopause, the estrogen is lost, so the dilator action of the upper airway is lost, and hence there's increased collapsibility of upper airway in sleep and increased incidence of sleep apnea. Again, progesterone has a stimulant effect on respiratory system, and this effect is lost. There is central fat redistribution. So we did a study of 1,000 healthy individuals, and what we found that 30% of them had sleep apnea, and it was not related to their weight. it did not correlate more to the BMI, it correlated more to the waist circumference. So as the waist circumference increases, central fat distribution increases, it increases the risk of sleep apnea. Then again, in menopause, there are hot flushes, night sweats. It causes frequent arousals, and because of this, there's fragmentation of sleep, and it increases insomnia in females. And this entity, comorbid sleep apnea and insomnia, around 40% of patients of insomnia, they suffer from COMISA. That is, they have sleep apnea along with their insomnia, and their sleep apnea needs to be treated. And why this is a concerning entity and why it is called comorbid. It is not called concurrent, it is called comorbid, because both disorders exacerbate each other, they worsen the quality of sleep, and they increases the risk of cardiovascular risk as compared to the individual disorder alone. So when to suspect this in our clinic? This is very important. Every one of you are running a menopausal clinic, and what questions you should ask to your patients to suspect sleep disorders. So you should, with every patient, you should ask, take the history of snoring, and it will be very surprising. The patient will deny that I do not snore, but when you will ask the husband, and they'll say that she snores a lot, and it will be surprising for the patient also, because they don't know that they are snoring or not. Then insomnia. Insomnia, as it was already discussed, is of 3 types: sleep onset insomnia, sleep maintenance insomnia, and early morning awakening. So what should we ask the patient? We should ask कि क्या आपको बेड पे लेटने के बाद आधे घंटे से ज़्यादा टाइम लगता है सोने में? If it is more than 30 minutes in falling asleep after going to bed, then it's insomnia. And if it is occurring for more than 3 months, then it's chronic insomnia. So that is what we need to ask. Another very important history is nocturia. Nocturia is not normal. Patient will say that हम जब ज़्यादा पानी पीते हैं तब रात में उठना पड़ता है. That is not the case. Nocturia happens if a patient is diabetic. But if the patient is not diabetic or the diabetes is controlled, and still if she has to wake up more than 2 times during sleep, then it may be a clinical clue for sleep apnea. Other things which we need to ask is tiredness throughout the day, or do you wake up with morning headaches, or do you don't feel like doing anything during the daytime. So these are subtle clues which tell us that patient may be suffering from a sleep apnea or a problem sleep disturbance which can be corrected. Now let's talk about the treatment. Lifestyle modification is the key. Every patient, we should spend some time in our OPD in telling about the importance of lifestyle modification. We think that patient must already be knowing it, but no. Sometimes reinforcing things help the patient to better understand the importance. Now, the importance of continuous positive airway pressure, CPAP therapy in sleep apnea. If a patient is diagnosed with sleep apnea, CPAP should be emphasized on. Patient should be counseled about the CPAP, that it is not habit forming, iska aadat nahi lagega, iska koi side effect nahi hai. And CPAP does wonders. The patient will say that हमारा insomnia improve हो गया, हम 17 साल से इतना अच्छा नहीं सोए जितना आप सो रहे हैं. So what does CPAP do? It acts as a pneumatic splint. It opens the upper airway during sleep. And it is not a medicine which is going inside your body and doing some side effects. So it is very safe and very helpful in patients who have sleep apnea. Then coming to cognitive behavioral therapy, which has already been discussed by previous 2 speakers. So I'll just elaborate on that. So what we do in cognitive behavioral therapy, it has many components. One of them is sleep restriction therapy. We ask the patient not to go to bed during the afternoon. Do not go to the bedroom only during the morning time. Engage yourself in some work. Then there is stimulus control. So what happens in stimulus control? We ask the patient to use bed only for sleep. Don't eat in bed. Don't watch TV in bed. Keep a chair besides your bed and watch TV while sitting on the chair, or eat something while sitting on the chair, because your mind should know that bed is only for sleeping. Whenever you go to bed, mind should correlate it now that I have to sleep. So this happens in this helps a lot in insomnia, and you can counsel this to a patient, and you can see there are some positive effects of it. Then there is cognitive restructuring, in which we address the maladaptive beliefs about the sleep. This is mostly done by a psychologist, and there are some relaxation techniques, there's myofunctional therapy, there's some exercises of the upper airway, which we teach the patients and which which go a long way in improving the sleep quality. Sleep hygiene has already been discussed, and everyone should follow it. It's very difficult for doctors to follow, but we should follow it. Now, coming to another case scenario, she was a 55-year-old female, again postmenopausal. She had frequent arousals throughout the night, low energy throughout the day. She complained of pain in legs while going to bed. And we did a sleep study for the patient, and this is how a level 1 polysomnography looks like. There are EEG recordings, brain waves, which are being showed here in the video of the patient. So I want everyone to concentrate on the video. So if you see, she is moving her legs during sleep, and she is sleeping, she is not awake, she is sleeping. This is the N2 stage of the sleep going on, and in between she is moving her legs. So what we found after we completed the sleep study, she had periodic leg movement syndrome, and her periodic leg movement index was very high, and the final diagnosis was obstructive sleep apnea along with periodic leg movement disorder. And then afterwards we reviewed the records, and she had anemia, she had microcytic hypochromic picture, iron deficiency anemia, and we gave her iron injections and her insomnia improved. So what I want to focus by this case is, again, we should ask, in any of your insomnia patient, you should always ask the history of calf pain or pain in legs while going to bed. If it's diabetic neuropathy, the pain will not improve by walking. It will be a continuous pain. But if it's a restless leg syndrome, the pain will improve by walking or massage. If she says कि हाँ कोई massage कर दे या दबा दे तो मेरा pain improve होता है, then it's very likely a restless leg syndrome. And you should do a iron studies even if hemoglobin is normal. You will see the CBC report and you can see it's a microcytic hyperchromic picture in many of the times, and hemoglobin may be above 12. Get an iron study done, and these patients respond wonderfully to iron therapy, and the insomnia improves. So this is what I wanted to focus. Restless leg syndrome is a primary clinical diagnosis. So these are the common disorders with which female comes to our sleep clinic: sleep apnea, insomnia, restless leg syndrome. And we should have a high suspicion while we are sitting in our OPDs, so that we can ask some more symptoms, and we can see that which category the patient fits in. So I'll just tell my key takeaways. Menopause significantly increases the risk of obstructive sleep apnea and insomnia. Every menopause clinic should consider sleep disordered breathing in women presenting with fatigue, insomnia, or mood disturbance. And thank you for not sleeping in my lecture. Thank you for the patient listening, and any questions I will be happy to answer.
Sir, thank you so much for a wonderful and elaborate.